Today's lecture is about time determinants of dental caries and the progression of the carious lesion. We said before that the factors involved in dental caries are tooth, the presence of a tooth, plaque, dental plaque, and a carbohydrate diet. And all these factors should present together in order for the carious lesion to form. And we said that caries is a multifactorial disease. And the effect of time is embracing the whole factors, which means that caries doesn't occur unless there is a good period of time for all these factors to work together in order for dental caries to develop. At first sight, these circles consists a simple model to explain caries risk, which represented by the overlap of the three main circles, tooth, diet, and plaque. With time, the circle has been supplemented with other factors, which we call them secondary factors, such as fluoride, saliva, socioeconomic status, and while one of the risk factor increases, the respective circle become larger. For example, in case of hyposalivation, which is considered as saliva, is a secondary factor in caries development. This is the example of how the circles increase. As you can see in the middle, we have the three main factors: plaque, tooth, and diet. Then time, topical fluoride, immune system, and every time we add another factor, a secondary factor, the circle enlarges. So what's the effect of time on the carious process? Caries is not a chronic disease, and its effect can be arrested or completely repaired if enough time is given for remineralization. Of course, this is at certain point, as we said before. Caries lesion does not develop overnight, but takes time. So all the primary factors should work together. Multifactorial. It is a multifactorial disease. Should work together. And should take a time before the carious lesion occur. It may take years for cavitation to occur, which gives the dentist and the patient time for the preventive treatment strategies. Teeth consists of calcium phosphate minerals that demineralize with the environmental pH lowers. If the environmental pH recovers, dissolved calcium and phosphate can reprecipitate on the remaining mineral crystals by a method we call it remineralization, or the process we call it remineralization. But unfortunately, remineralization is a slower process than demineralization. Rule of fluoride. When remineralization is given enough time, it can eliminate the damage done during demineralization. But in absence of this, the caries process will progress and the lesion will develop. For many years, much emphasis was given to the pre-eruptive effect of fluoride, improving the quality of the dental hard tissue, which means fluoride that is ingested before the eruption of the teeth. It is, however, it's now clear that post-eruptively used fluoride is more protective against caries, which means fluoride that is supplied or given after the eruption of the teeth in the oral cavity. It was noticed that excessive fluoride in the drinking water, more than 2 parts per million fluoride, resulted in molting appearance of enamel. A phenomenon that is called enamel fluorosis. Enamel fluorosis has degrees from mild, as in the picture in the lower left, to moderate, as in the picture in the middle, to very severe and can result in bad discoloration of the teeth, as in the photo in the right side. Enamel fluorosis also, other than causing staining of the teeth and molting of the teeth, also was noticed that is related to a low prevalence of dental caries, which means increase the tooth resistance to demineralization. Later, after they found that teeth exposed to fluoride has resistance to demineralization, studies found that when the drinking water contained about 1 part per million fluoride, The teeth of the inhabitants of that area had low caries prevalence but no signs of dental fluorosis. So we can, with a fluoride of 1 part per million, there is the benefit effect of low caries and without the side effect or the bad effect, which is fluorosis. Because of some problems with water fluoridation, which means adding fluoride to the water in a certain percentage, as we said 1 part per million, which is the safest percentage for as we said earlier, for prevention of caries without the side effect of fluorosis. But there are problems with this to make it popular, or to make it common, or to make it on public. There were alternative methods of supplementing fluoride intake has been developed, and this will be covered more in the preventive course. One of the most common and popular ways for adding fluoride is the fluoride toothpaste. It is by far the most frequently used fluoride agent in the world, but unfortunately it is used regularly by fewer than 10% of the world's population, about a third of the population of industrialized countries. So how fluoride helps in the prevention of dental caries? We have to return back to the crystalline structure of enamel. Enamel is composed of hydroxyapatite crystals, Ca10PO4 taken 6 OH taken 2. It's not a pure hydroxyapatite though. It is also has a non-apatite phase, which is the amorphous calcium phosphate or carbonate phase. Enamel is also porous, allowing ions to diffuse into it. So the composition of this hydroxyapatite lattice or crystal can vary throughout its structure and throughout time of the enamel. In other words, the crystal lattice has the capacity to substitute other ions of appropriate size and shape. For example, within lattice, calcium can be exchanged for radium, strontium, and hydrogen ions, and phosphate can be exchanged for carbonate and hydroxyl for fluoride. And this is important for the fluoride, since the hydroxyl in the hydroxyapatite crystal can be substituted by fluoride if fluoride is available in the environment, which means in the saliva, in the plaque, in the oral environment. And fluoroapatite crystals are more resistant to demineralization than hydroxyapatite crystals. Substitution or deposition of fluoride in enamel can happen during 3 times: during tooth formation, during the formation of the tooth while the tooth is still forming, low concentrations deposited during tooth formation because of low fluoride concentration inside the tissues, after calcification but before eruption, which means after the tooth formation but before eruption of the tooth in the oral cavity. More fluoride is taken up by surface enamel, which is in contact with the tissue fluids, but most of the fluoride is taken to the tooth structure after eruption of the tooth in the oral cavity and throughout the life of the tooth. The enamel continues to take up fluoride from the external environment, which means by supplements that bring the fluoride into the oral cavity. The fluoride content of intact surface is much higher than the interior enamel, but tend to be exactly variable. It varies between primary and permanent teeth, between individual different teeth, though in teeth in the same individual varies also difference, and even the tooth surfaces differ in their content of fluoride in the same tooth. So, how fluoride works, or what is the karyostatic mechanisms of fluoride? Fluoride can work by many ways for prevention of dental caries. First one, once teeth have erupted, fluoride inhibits demineralization by reprecipitation of dissolved calcium and phosphate into the enamel. Fluoride also promotes remineralization. Part of the reprecipitation is on the surface, which narrows the pores of the enamel surface, which prevents acid penetration, thus encouraging repair or arrest of the carious lesion and delaying the lesion progression. So fluoride helps both in that inhibits demineralization and promote remineralization. Fluoride also can exert a bactericidal or anti-enzymatic effect on the bacteria. Fluoride also interferes with ionic bonding during silica and plaque formation on the tooth surface, and also, as we said, improve enamel crystal structure by forming of a fluoroapatite, which is more resistant to acid attack than the hydroxyapatite crystals. Rate of caries progression means how long does the carious lesion takes to form and to develop and to progress. Caries lesion progress more slowly than they did several decades ago, which may be related to the increased use of fluoride. About 50% of the enamel fissure lesions had progressed to involve dentin within 2 years, while 75% have become dentinal lesions after 4 years, so we still have time to interfere with the carious lesion. It needs about 3 to 4 years of proximal carious lesions to reach dentin. Caries on free smooth surfaces seems to progress more slowly than on proximal surfaces or in fissures. Along with the decline in caries prevalence has come also a decline in caries progression rate. Between the initiation of caries and the involvement of dentin in the caries process, there is ample time for preventive management strategies, which means that we have time between the initiation of caries and the reach for cavitation, which is the way, as we said, or the point at which there is no return. So we have time to interfere or to capture the caries process at this time, the time that we can interfere by remineralization. While free smooth caries seem to benefit the most from the apparent caries decline, occlusal surfaces of molars and premolars seem to have the least benefit. This is because the fluoride effect is more on smooth surfaces more than on occlusal surfaces. The degree of destruction caused by caries that allows the region to heal or to be arrested is an important question. It is the point of no return, the most important time of the carious lesion. The point of no return means a need for restoration, which is when the cavitation occurred, that we cannot reverse the carious lesion by remineralization. This point is very crucial decision in the life of any tooth.